The proceeding will start shortly.
Thank you for having been through that process to check that we can hear and see you all and you can hear us. As you know, this meeting is going to be broadcast live, so if there are any technical hiccups, which we hope there won't be, we will have to temporarily suspend the meeting whilst they're resolved, but I'm optimistic that we will get through relatively smoothly. Can I thank our witnesses for being with us today, Professor Marmot, Professor Rasul and Ms. McKeown, and can I just check that you're all happy that I refer to you by your first names? If you're content with that, can you just nod? Yeah, we've got nods there, brilliant, thank you very much. As you'll have heard, you don't need to worry about your own microphones, they'll be automatically unmuted for you. It really helps me if you can indicate which witness it is you wish to put your question to, or if you wish it to go to all witnesses, then I will go to them in turn to give their answer. That just helps for the broadcast and sound people to make sure that it all runs smoothly. The meeting is scheduled to conclude by 4:30, so I think that gives members about 15 minutes each for their questions. So I will be quite rigid on timing, for which I apologise. And the other thing that really helps me, if when you have finished your section of questions, if you don't have any more questions, could you just let me know? But additionally, if you want to come in at any point, and this applies to the witnesses, please raise your hand and give an indication if there's something that you want to come back on further, perhaps when one of the other panellists has spoken. But to committee members, either raise your hand or send a message via the group WhatsApp, and I'll know to bring you in. And I would like to start now. So order. Firstly, can I thank the witnesses for being here today. I'm going to give you all the opportunity to give a brief introduction as to who you are and how you can help us with this inquiry. But can I ask that you frame it in terms of, we know on Monday the Health Secretary indicated to us the review that is being carried out by Public Health England into the data around what we know of how COVID-19 is impacting different communities. And I'd be very interested to know whether you will be feeding into that review, or if not, how you would feed into it if you were invited to. And can I start with Professor Marmot, please?
Thank you, and thank you for inviting me to give evidence to this committee. As I hope you know, I was responsible for a publication. It feels like a different geological era, but it was the 25th of February this year. Health Equity in England, the Marmot Review, 10 years on. And we were concerned with inequalities in health. Most of our work was inequalities, thinking of socioeconomic inequalities. We did refer to ethnic differences where we had data. And we pointed out that the data are not routinely collected that way. So there is a problem. We also were concerned, obviously, with gender, but much less data on sexual orientation, and also much less data on people with disabilities. So these are all important questions. I think it highly likely that much of what we covered does apply to groups with special characteristics of concern to this committee. But because of the limitations of the evidence, we didn't say so very much about them. Where we did refer to ethnic differences in life expectancy, we pointed to the lack of uniformity by ethnic group. It depends which ethnic group the people belong to. But in general, the social determinants of health and health inequities do apply to these groups of special interest. And my general view as to what's happened since is that the pandemic has exposed and amplified the underlying inequalities in society. And the response to the pandemic, likewise, the lockdown, will have the effect of increasing inequalities. And we can talk about that more.
Thank you. Professor Rasul.
Thank you. Let me start by thanking you for inviting me here today to give evidence. I'm a professor of economics at University College London. I'm a research co-director of the research centre within the Institute for Fiscal Studies. So most recently, I've been involved in work looking at the short-run impacts of the current crisis on a range of different dimensions, both looking at how key workers are being impacted, differences across different minority groups, as well as some more recent work thinking about differences in the geographical impacts of the crisis in the UK along different dimensions. So my expertise really comes from the use of administrative data to really document what was happening in the run-up to the crisis. And as Michael mentioned, there's been a lot of work done at IFS looking at the drivers of inequality in the UK and how some dimensions of inequality have increased in the run-up to the crisis, and how the current situation has amplified some of those differences, but also made us more aware of new dimensions of inequality that may well be relevant for policy and sort of the dynamic impacts of the crisis going forward. So those would be the types of things I'd very much like to feed in both today and if I were invited to give evidence to the wider review. And just as a bit of background, I have done some previous work looking at other epidemics and pandemics. In particular, I have work studying the impacts of the Zika crisis in Brazil, as well as the impacts of Ebola, and really trying to understand how did those shocks impact both societies in terms of health responses, how people respond to information about those outbreaks, and what are the short-term and long-term economic impacts of those crises. So this is following sort of a broader agenda that I think economists have been interested in, as really trying to understand how robust are our economies, what are the impacts on different groups from these very aggregate, sudden and uncertain types of shock.
Can I just ask, when looking at the economic impact on different groups, did you specifically break that down after previous crises into gender, people with protected characteristics, perhaps disabled?
So in terms of the earlier pandemics that I've studied?
Yeah.
So in the context of the Zika crisis, the most at-risk group were pregnant women. And so we're able to use administrative records from Brazil to try to understand how, if there's a particular group at risk, how do they change their behavior with the supply of new information? So how do they change their likelihood to become pregnant? How do they change behavior during pregnancy? So that was very much focused in on a particular group that was at risk. And we documented how the responses to information that were provided by the Brazilian government at the time varied across the socio-economic status, varied by marital status, by age of women, their educational background, and so on and so forth. So that gives us one context in which, you know, how do households respond differently to the same types of information? How long does it take them to get back onto their types of behavior that we observed pre-crisis? In the context of the Ebola crisis, I was working in Sierra Leone. And there we were understanding how adolescent girls and young women aged between 12 and 24 but were impacted by the crisis. In particular, how school closures during the crisis may have led to persistent impacts on those girls' ability to acquire schooling even after schools had reopened. That there are many elements of these crises where short-term policy responses can feed into more persistent impacts. And I think that might be some of the issues we'll touch upon a little bit later, and that's what we started in that context.
Thank you very much. Liz McKeown.
Thank you very much. I'm the Director of Public Policy Analysis at the Office of National Statistics. At ONS, our role is very much about providing the data, the statistics, the analysis needed to serve the public good. And what I think that means in the current COVID-19 pandemic is making sure that both the public and policymakers are informed about what is happening across both UK economy and society, and also given the information and the evidence needed so that we can manage the pandemic in the best possible way. A key part of that is understanding how different groups' experiences are varying over this period. And we have done a lot of work both on the current data and statistics that we have, to understand how that might happen, and then moving on to think about actually how can we fill evidence gaps that are likely to happen. And we've done a lot in a short period of time to stand up some new surveys to give new evidence, and also to bring in different data sources that can help shed light on some of these issues. And hopefully there'll be a chance to talk about some of those developments over the next couple of hours.
Thank you. I'm going to bring in now the first committee member to ask a question, which is going to be Nicola Richards.
Thank you, Chair. My questions are to Professor Marmot. Your earlier 10-year review was published earlier this year, as you already mentioned, and in it you said the government had not prioritised health inequalities and noted there'd been no national health inequality strategy since 2010. So what impact, if any, has it had on the government response to COVID-19?
I would imagine it's had very little impact so far because the urgency of responding to the pandemic. I was encouraged after the 25th of February. The very next day, there was a question to the Prime Minister at PMQ, and the Prime Minister responded very positively. I mean, part of my key recommendation was that the Prime Minister should lead a cross-government health inequality strategy, and that to fulfill his stated ambition of levelling up, we'd given evidence on the areas where investment was needed. There was a debate the following week in Parliament, I think a 3.5-hour debate about my report. And as I read Hansard, both sides seemed to all sides seemed to accept the importance of the findings and that action needed to happen. So I was really pretty encouraged that we might get somewhere. And then, of course, the pandemic swept over us. So I don't think too much has happened along those lines directly. That said, what the Chancellor did in trying to support the salaries of employed people who are furloughed is a form of universal basic income. I was far too shy to recommend universal basic income, but the Chancellor just did it. So the trying to support the social and economic conditions of the worst off, it seems to have been part of government strategy. I don't think it was an explicit response to my report. And I would hope that as we start to emerge from lockdown and from the pandemic, that my report will indeed become part of the discussion of what kind of society we want to create.
Thank you. But are you concerned overall that COVID-19 will entrench existing health inequalities even further?
Oh, I'm terribly concerned. We can see it already. The Food Foundation reported on Monday that of families with children, 5 million adults and 2 million children had experienced food insecurity since the start of the lockdown. Wow. People don't have enough to eat. I mean, what most of us agree that a fairly basic measure of a civilized society is everybody can eat. In public health, we're concerned about the quality of food, of course, but if people can't eat at all, they're actually going without food, having smaller meals because they can't afford it or lack of access. This will entrench and make worse existing inequalities. Once the furlough scheme starts to tail off, and today's news was that the Chancellor is considering how to tail it off, that will again be likely to entrench inequalities. That Imran doesn't need me to quote the IFS, but I will anyway. No, actually, I'll quote ONS. Imran can quote IFS. Let me quote IFS. ONS. ONS reported that before lockdown, if you look at workers in the hospitality industry, 10% said they had the ability to work from home, whereas people in communication and the like, 53% said they could work from home. And what we know is the lower your income, the less likelihood there is of working from home. So those people will have to go out to work, which puts them at risk, or become unemployed. And if their salaries are supported to 80%, but they were at the poverty line, they're now below the poverty line. So there's going to be severe difficulties of exaggerating social and economic inequalities, and that won't be solved overnight.
Thank you. Thanks, Chair.
Can I bring in Alex Davis-Jones now, please?
Thank you, Chair. My initial questions are for both Professor Marmot and Professor Rasul. We are getting evidence of the disproportionate number of Black, Asian, minority ethnic and people, and also men dying from this virus. It's still emerging. At this point, to what extent is this because of the nature of the virus itself, or is it because of wider social factors? What's your interpretation?
Well, there was a paper published yesterday from Oxford University, which I feel I could have written. It said exactly what I thought about the issue, which was two things. One, when you take the Black, Asian, minority ethnic groups overall, the high risk is largely it could largely be explained about social disadvantage. These groups, on average, tend to be poorer, more crowded households, multi-generational households with greater likelihood of transmission within that household, lower status jobs, the things I've just been talking about, having to go out to work. Happily, in the UK, we don't think it's a health service issue. If we're talking about the United States, we'd be saying that Black residents of the US are less likely to get adequate health care. But we're blessed with a national health service with equity of access. So we don't think it's lack of access to healthcare. We don't think that's the issue. And in fact, this paper published yesterday shows that the proportion of BAME patients in intensive care is higher than the average in the population. So I think in general, we don't have to think about the nature of the virus. We can probably explain most of the excess on social determinants of health. But what about the doctors?
Yeah.
Now, I can't get my head around that. I don't know. Something like 40% of doctors in the NHS are from BME backgrounds, and 95% of the deaths. Now, I wouldn't imagine doctors are suffering from social disadvantage or poverty, overcrowding, maybe multi-generational households. I don't know why the doctors seem to be at high risk. It's terribly important. I don't think it's readily explicable on the basis of the kind of things that I was talking about. And maybe we'll understand more about this terrible disease if we can explain that.
Thank you. Professor Rasul, I don't know if you had anything to add to that point or if you wanted to come in there.
So let me summarize some recent data work that IFS has done on particularly this issue, and sort of highlight some of the wider implications of that, and thinking about to what extent can we attribute excess deaths to, say, demographic factors, pre-existing health differences, vis-a-vis those that might come from exposure, say through the workforce or through the labour market. So I think the first key point is that there is large degrees of heterogeneity across different minority groups, and it's not useful to think of all of them as one homogeneous category. And so I think the evidence that we've put together suggests that there are some groups who have excess deaths and others that don't, and the underlying reasons for this that may be very different. So it just in raw terms, the Black Caribbean population has a death rate which is about double that of the white British population, whereas Bangladeshis are slightly below that of the white British population. There's tremendous amounts of heterogeneity just looking at the raw numbers. The second thing I wanted to emphasize was that there's many different outcomes that we could consider here. One is death rates as caused by COVID. Another potential outcome that I think has been less studied is in terms of excess deaths and the extent to which excess deaths, namely the total number of deaths, irrespective of cause, relative to, say, some long-run average at this point of the year, how do those excess deaths also break down across different minority groups? So a fraction of them will be due directly to COVID, but an additional amount, perhaps even the majority of them, will be caused by other factors related to the reallocation of resources around the health service, and that may also disproportionately affect minority groups. And so I think a lot of the discussion so far has been in terms of differences in COVID-related deaths, but there may be other elements of death that become increasingly important, both in the short term and in the longer term. So what the analysis shows is that when you try to condition and take account of just basic demographic factors and take account of the fact that minority populations are concentrated typically in urban areas where there's been higher caseloads, higher death rates, and at the same time also take account of differences in age structure, then you find the raw differences in death rates actually get extenuated even further. That you might think that the difference was down to geography, and that narrows the gap a little bit. But the fact is that most minority populations have demographic age structures such that it becomes even harder to explain some of these differences across groups. So basic demographics don't seem to do it. They seem to extenuate some of these differences. There are a whole range of other risk factors that Michael's already touched upon. So families and household structures differ tremendously across different groups. So, for example, South Asian groups are much more likely to live in larger households. To give you an indication of the extent of those differences, if we just focus in on London, around a third of households are single person households. But amongst households where the household head is Bangladeshi, Indian, or Pakistani, those figures are 11%, 17%, and 13%. There's a wide difference in those household structures. In addition, compared to white British households, minority ethnic groups also tend to live in more overcrowded accommodation, even once you control for a particular region of residence. So, for example, fewer than 2% of white British households in London have more residents than rooms. In contrast, this figure is around about 30% for Bangladeshi households, 18% for Pakistani households, and 16% for Black African households. And so those types of household structures and density is likely to make self-isolation harder and also increase the opportunities for within-household transmission. So that probably plays an important role. However, such overcrowding is not so prevalent for Black Caribbeans, who are the one group who have the most excess deaths relative to the white population. So the obvious remaining factor is what Michael was suggesting, which is pre-crisis differences in health conditions amongst these groups. And there you see a very striking pattern that for many minority groups, their preconditioning health status tends to be worse on a whole range of different margins, which you might think make people particularly susceptible to COVID. But there's a very strong age gradient there. So when we talk about younger people in minority groups, they actually have lower rates of pre-existing health conditions than the white British population. Where minorities have worse health conditions pre-existing is really amongst the older people in those populations. So for both Indians, Pakistanis, Bangladeshis, and Black Caribbeans, pre-existing health conditions amongst older members of those communities are much more prevalent than amongst the white British populations. You can see how these two things might interact to really be driving some of the differences that we see. And so coming back to my earlier point about distinguishing between direct deaths caused by COVID from indirect deaths that might be caused from other reallocations in the health service or people delaying going to hospitals, we've seen a huge drop in A&E admissions, for example, and those might be directly related to some of these preconditions that older minority groups suffer from to a greater extent. So I think it's not a matter of demographics. It may be a matter of some of these household conditions or these pre-existing health conditions, and more work needs to be done to really try to tease apart those elements. Then in terms of exposure at work, Then we can also look at the extent to which minority groups are involved as key workers. And so there we see, again, a lot of heterogeneity across different groups. So you have, if we look at the share of all workers in a particular group, Black Caribbeans and Black Africans have a greater share of people who are working within those groups, who are working in key worker sectors. So, for example, the share amongst white British individuals working as a key worker is about 21%. That corresponds to the share of Black Africans who are working just solely in health and social care, even ignoring all the other sectors in key work. So there are large disparities there. And some other groups, such as Bangladeshis and Pakistanis, are less exposed through key worker sectors and occupations.
Thank you.
Then there are also differences across these groups in terms of employment and income risk as well, in terms of sectors that they've been exposed to which have been shut down. We know that shut down sectors are more likely to be lower pay sectors. Even amongst sectors that remain open, lower paid jobs within those sectors are less likely to be able to be done from home. So on both dimensions, both across sectors and within sector, you're seeing impacts at the low end of the income distribution, where some minority groups tend to be concentrated. So I can talk further about impacts in terms of the ability to save and resilience across these different groups. One final point that I'd like to emphasize is that, many minority groups tend to be overexposed through self-employment as well, where it's been somewhat hardest for the government to implement policies to provide financial support to that group. And so, for example, Bangladeshis, especially Bangladeshi men, are far more exposed through self-employment than are white British men or any other male group amongst any of the other minority groups. So maybe I should stop, then we can come back to some of the economic impacts across groups a little bit later. But it's essentially a combination of all of those factors, but demographics and age would just make it harder to explain these differences across minority groups.
Okay, thank you very much. I think, Liz, did you want to come in there as well?
Yeah, if I could come in briefly, just to add to a couple of points we've just heard there, because I wanted to flag to the committee that we have some forthcoming publications that I think will shed further light on some of the issues that have just been raised. Tomorrow, we will be publishing an analysis of ethnicity and mortality. And what we have done in that analysis is linked death registrations to data from the 2011 census, where we can get ethnicity and other characteristics from. And those other characteristics will allow us to explore some of those questions that were just being discussed. It's a rich data set. And so we'll obviously share the findings of that after publication with the committee. And I think that will be very useful to address some of those questions. The other area I wanted to pick up on was the talk of how different groups are exposed to COVID-19 at work. And next week we will be launching a publication which looks specifically at that issue. So it uses a technique to see how much different occupations are both exposed to infection and also how proximate they are to other individuals at work. And so it allows us to think about risk of COVID-19 at work for different occupations. But of course, then what we can look at is how those occupations, how different protected characteristics work in those occupations. So some occupations are overrepresented by women or by ethnic minorities or what have you. And so again, that will add to our evidence base in this area and begin to fill in some of the gaps. So taken together, both the IFS work last week and these forthcoming publications, I think will give us quite a rich picture of what's happening with ethnic minorities through the pandemic.
Thank you. If I could come back to the UK's government response in identifying these specific at-risk groups, have your organisations been able to do any analysis and comparisons with other countries in the world who've dealt with the coronavirus and have seen similar results? If you have, where does the UK's response rank, I suppose, in terms of this?
Well, I just a little earlier today come off the telephone with people at WHO in Geneva, WHO headquarters, and we're trying to look at exactly this question, inequalities in COVID-19. And the first thing that's very clear is how blessed we are in the UK with good data. Liz, I'm not saying this just to make you blush, but we cherish ONS. The series of reports and the data that come out of ONS are extremely valuable. And most countries just don't have that, beyond, certainly in low and middle income countries. So it's extremely difficult. We want Tedros, Dr. Tedros, to be able to say, we want to provide him with the evidence so that in his briefings, he can talk about the inequality impact of COVID-19. But getting the evidence for him is extremely difficult. Now, so that's the general issue. It's highly likely that particularly in low and middle income countries, we have a little bit of data coming from India, that the impact is absolutely catastrophic. If you're a migrant worker, the majority of employment in India is in the informal sector. And so there's no such thing as furloughing with 80% of pay. You're an informal worker, a migrant worker, you're out of work, you're homeless, and you're hundreds of kilometers from your home visit, no access to food, medicines, healthcare. It's catastrophic. And we don't have very good data is the problem. So as I mentioned a bit earlier, when we look at the United States, where we do have better data, the problems that Imran and I have both been referring to are amplified by the inequities in access to healthcare. The United States doesn't have a healthcare system. It has a healthcare sector. It's an economic activity for the country, and it's exposed at times like this. So it's made very much worse. We do see the excess amongst African Americans, and interestingly, and I say interestingly because Hispanic Americans, there's the so-called Hispanic Paradox in the US, that overall life expectancy seems to be better for Hispanic Americans, but they certainly seem to have an excess in mortality associated with COVID-19. And that indeed may again be partly a healthcare issue, as well as all the other kinds of issues that Imran was talking about.
Yep. Sorry, Professor Rasul, if you want to come in there.
So just to follow up on your point about international comparisons, I think there's been obviously lots of discussion about, league tables and how the UK's response is comparing. And, a lot of that is discussed. There are just differences in methodologies about how data is being collected and what it represents. And I wanted to echo what Michael said to Liz. We're in a very fortunate state in the UK with the data that we have through ONS and other sources. We're in a very tremendously strong position to base our decisions on actual real-time evidence. But when we're making those comparisons across countries, we have different rates of testing, different types of testing. That's going to lead to differences in case counts. How we count deaths, whether it's in hospitals and social care, that varies across countries, whether we use deaths from COVID, whether we use excess deaths, those are all going to be measurement and methodological issues that will make cross-country comparisons difficult. But imagine we put all of those to one side and we said everybody supplies the same data. Could we then still make useful cross-country comparisons? Then I think the thing to start with is to say the only thing that's common across all countries is the basic epidemiological model of transmission. Let's assume that the rates of transmission are the same. The biology of the virus is the same. But how that then mediates or translates into deaths or cases or anything else that you're interested in is always going to be mediated by a variety of different factors. The first is what we've been discussing so far, the underlying social structure in that society. What are the initial levels of inequality? What are the particular dimensions of inequality that differ across societies? And how different minority groups might be in very different circumstances in different countries. And so that's going to lead to some differences in, just naturally across countries. The second element is going to be the policy response that countries have initiated. And, there the devil is really in the detail in terms of exactly what is implemented, the timing of that implementation, the extent to which that policy is enforced. And I think, as Michael was suggesting, when we look really across the global income distribution, then a key factor is just the ability and the capacity of the state to provide resources quickly and in a targeted way to groups that are most at need. And I think we've had very good examples in the UK of how our underlying infrastructure has allowed us to target resources to those most in need in a very quick way, given all the other circumstances. So there's differences in the social structure, differences in the policy response, and then differences in how households behave. Households will respond differently to the same types of information across countries, but the information that's being provided is coming from a variety of different sources there. So in a sense, to try to disentangle those elements is a very difficult, complicated task to do. To then say this gives a clear ranking of the effectiveness of policy, it's difficult when all of these other factors are also different across countries in terms of the underlying social structures, which policies are implemented, and household behaviour. So it may be that in the longer term, we can make sensible comparisons across countries. I think that will be rather painstaking work and subject to lots of caveats if we go down that route. And what I might also highlight to the committee is that perhaps in the shorter term, it might be as important to put emphasis on trying to understand what's happening within a country across different parts of the country, where we might say, look, the policy environment is somewhat similar. What's different in different parts of the country are these social structures and how households might be responding and some of the group differences. And that might give us a better handle on the extent to which the same policy is effective in some areas and hasn't been effective in other areas. And that might, in the shorter term, shed much more light on how well the government is doing than trying to make comparisons across countries, which are fraught with methodological as well as the confounding factor differences. And some of the most recent work we've been doing at IFS has been really trying to understand that geographic variation in the crisis and which parts of the country will be hit on different dimensions of the crisis, and whether one policy can deal with all of those, or whether we think that we're going to need a whole range of different policies to try to deal with that geographic dispersion.
Okay, thank you. Liz, did you want to come back in there as well?
I largely agree with what's been said. Significant methodological challenges when trying to make international comparisons. I agree with Imran that over time they will be possible, and they'll be possible when we have the sort of depth and breadth of data on deaths registered across different countries that we are striving hard to produce in the UK now. But we know that sort of data is not currently being produced in all countries, so those comparisons are currently possible in that way. We very much in ONS will continue to look at the disaggregations we can produce to help inform policy in this area. Last Friday, we produced a large amount of a publication looking at geographical variation at different levels, including allowing people to look at how deaths varied at relatively local levels, which has been of significant interest to both the public and to policymakers. And our work tomorrow on ethnicity will be another chance to look at how mortality is varying across different groups. Next week, we will be looking at occupation in a similar way, and carrying on building up the evidence base in the way that Imran suggested within the UK, while also looking ahead to a period where those international comparisons will be more possible, is the way we're going at the moment.
Okay, thank you. Are there any immediate actions that you would like to see the government implement in order to protect these at-risk groups more? And is there any recommendations that you have for them, so that anything that can be done immediately?
The answer is yes. I think that the report, my 10 years on report, gave a framework of understanding of the causes of health inequalities and overall health of the population. So through the life course, we look at early childhood, including poverty and services for early childhood. We know that when we look at education, that what we're indulging in a way, is an extended summer fade experiment. We know that when you look at inequalities in educational outcome, children from more disadvantaged backgrounds, their disadvantage in learning increases over the summer. So they start the new term when they come back in the autumn at disadvantage. The disadvantage tends to lessen over the school year, and that increases again next summer. And the likely explanation is kids from more privileged background have, I'm shy here, books in the house, and parents who can foster learning and the like. And so with the lockdown of schools, it's like an extended summer fade effect. It's highly likely that the inequalities in learning will increase. And I could go through the rest of it. We talked, the third one was about employment and working conditions, which we've already been talking about. Then money, having enough money to live on. And the fifth one relates to communities, housing, and the like. I think it is absolutely vitally important and urgent to look at each of those and say, what do we need to do with urgency to make sure we're not increasing inequalities? Conditions for early childhood, for education, for each of those. And I think there are things that we can do on all of them.
Any specifics you'd like to mention? Any recommendations you'd like to see implemented now?
Well, I don't want to trivialize it by just pulling things off the top of my head, but I'm particularly concerned about the likely increase of educational inequalities with the closing of schools. And so for me, it's a matter of urgency to pay attention to how we can do it, reopen in a phased, graded way with all attention to safety. It means looking at the transport system, having the proper public health in place, so testing, tracking, and isolation, which has got to be done with the reopening anyway, but giving priority to that, and paying attention to, well, is there more that we could do to redress the likely amplification of educational inequalities? Now, I say I could go through the rest of it in similar fashion, but that's the kind of thing that I would like to see us paying attention to.
Okay, thank you very much. Professor Rasul.
So I mean, just briefly, I would emphasise that there's a very important interaction here of age with minority groups here that comes out quite strikingly when we look at the data. So we already mentioned that household structures, household overcrowding is different across different groups, to the extent that older people in those minority groups are more likely to find it harder to self-isolate. And as we think about policies to move us out of the lockdown, and we recognise the need perhaps for older people to remain self-isolating, that's going to be much harder to do for some groups relative to others. And so that's an important factor to bear in mind. The second is what I already mentioned, sort of the strong age gradient in health preconditions that is very striking for minority groups as well, that older members of those communities are in worse health pre-crisis than people of a similar age in the white British population. And then older people in those groups, in some of those groups, are being hit by a triple whammy in terms of their exposure to shutdown sectors. So when we look at whether you work in a shutdown sector and how that varies by age, we find starkly different patterns between some minority groups and the majority population. So amongst the majority population, it's very much younger people who are employed in many of the sectors that have been shut down, whether it's retail, tourism, and other sectors in which face-to-face contact is important. That pattern is completely reversed amongst Pakistanis and Bangladeshis, whereas older individuals are more likely to work in some of the shutdown sectors, presumably because of channels of self-employment or working in retail. And then in other groups, such as the Indians or Black African populations, there's essentially no difference across age groups. All ages are similarly exposed through these economic channels. And so that there are some important interactions between age structures and minority groups that makes older individuals, especially amongst Pakistani and Bangladeshi groups, particularly susceptible on this whole range of dimensions. We might say, look, none of this really matters as long as there's somebody else in the household who is able to work during the crisis. But when you look at household compositions and the extent to which you have a working partner who's not affected by a shutdown sector, that again varies tremendously across different groups. So for example, amongst white men who are in a shutdown sector, around about half of them have a partner who's still in paid work at the current time. But that's quite different amongst minority groups. So again, amongst Bangladeshi men, about 47% of them are in a shutdown sector, and 2/3 of them have a partner in no paid work. And so for those households, the consequences of being in a shutdown sector are even greater than for some other groups. And for Black Caribbean men in shutdown sectors, the majority of them are either single or lone parents. And again, so absent another individual in the household who could potentially be earning and helping to smooth some of these shocks. So there do seem to be important markers that suggest that some households will find it difficult both in the current crisis, but also as we try to come out of the lockdown, how different households might be differentially able to self-isolate or to recover back in terms of some of the economic losses as well.
Okay, thank you very much. I just got one more question, which is for Liz, actually. You mentioned your new report that's due to come out where you've had to use census data in order to gather some of this intel. Now, the Home Office have said that they have no plans to include ethnicity on death certificates and on death registrations. Do you agree with that? Would it be a lot more easier if this was included for you? What's your opinion on this?
So it's not for the ONS to determine what's on death certificates, but we are obviously really interested in making sure that we can produce the information that's addressing some of the big questions at the moment. And of course, one of the big questions at the moment is how mortality is varying by ethnicity. So we had to be creative at that point in our analytical approach to think about how we could address that. And our ability to address that was by matching across to the 2011 census information. And that matching has been effective. And as I said, the findings from that will feed through tomorrow. I think there's a lot of different considerations that have to be weighed up around what is on a death certificate. And the costs and benefits of including more information on there in terms of overall quality of information that you then are able to obtain. And so our focus has been on with what is available to us, how can we produce the richest possible evidence base.
Okay, thank you. Thank you, Chair. No more questions from me in this section.
Thank you. Can I make a plea to our witnesses? Could we have slightly shorter answers, please? I have a lot of members wish to ask you questions. And can I bring in Nikki Aitken, please, who wanted to follow up on the comment about education?
Thank you. Yes, it was for Professor Marmot. You were talking about the problems of particular ethnic minorities in education attainment. But I've been very interested to see the Select Committee, the Education Select Committee, are now looking at the fact that it's white working class boys who tend to be more affected by poor education attainment, particularly in South Wales and other parts of the United Kingdom. And for my own constituency in the cities of London and Westminster, my experience has always been that the Bangladeshi, Pakistani, Indian families are very much about education attainment, and more of their children go to university than I'd say white working class boys. I'd just be interested in your views.
Yeah, I was referring to socioeconomic differences, not ethnic differences. And when it comes to looking at ethnic differences, then Imran's point applies. I think there are real differences in different ethnic groups. It's not uniform. If you talk to people in different parts of the country, you come up, and I think the data confirm it, with a picture that people of Gujarati background educationally, they do better than the English average. People of Pakistani background do less well than the English average. So it's not uniform. And I was referring to socioeconomic differences. And as you say, the boys, the white working class background, do poorly. There's a very clear social gradient. It's not just that there's one subgroup that do poorly. It's a very clear social gradient. The more deprived, the worse they do. And then the ethnic difference is not quite orthogonal to that, but it doesn't map completely on the social gradient because, as I said, there are these differences among different ethnic groups.
Thank you.
Can I bring in Peter Gibson now, but I think on the specific questions that we've already been asking?
Thank you, Chair. So this question is directed to Professor Marmot. You talked initially about the fact that COVID-19 has exposed and amplified inequalities in health. Looking at the fact that it seems to have had a pronounced impact on those with certain protected characteristics, do you believe that this was foreseeable? Could you comment upon the impact specifically upon men and why the impact seems to be falling greater on the male population? And you interestingly commented upon the differences between our healthcare system and those in America and highlighted the inequalities there. Just to give the committee some balance in terms of other good practices, other healthcare systems without the same systems as the United States, could you highlight some other countries and their healthcare systems without those inequalities?
Yeah, thank you for those questions. Most of my responses, as I said at the beginning, and I apologize for this because I've already misled 2 committee members and probably more. Most of my responses were around, in general, socioeconomic differences in health. Those were the inequalities we analyzed. And as I said in my introductory remarks, it's largely because we didn't have the evidence on the other protected characteristics that are the interest of this committee. So to me, it was predictable. I was asked on Friday, after the ONS published its mortality by levels of deprivation, COVID-19 mortality, I was asked, was this a surprise? And my answer was no, not at all. I'd been imagining that's what we would see. I just hadn't seen the data till then. And then ONS published it on Friday, and it was very clear. And what was clear was the social gradient that I've been talking about. But if anything, the gradient for COVID-19 mortality was slightly steeper than the gradient from all causes. So yes, it could have been foreseen. I certainly predicted it, that from what we understood about transmission and the importance of social distancing, for all the reasons we've rehearsed already this afternoon, social distancing is far more possible for people at greater social advantage. And to the extent that people from different ethnic groups, those who are disabled, to the extent that they're less able that they're less likely to find themselves in a position that makes social distancing possible, they will be at higher risk. So that part was all predictable. What wasn't, to me, predictable, but this may just represent the depths of my ignorance, was men, the excess in men. And please don't misunderstand me if I say I'm confused about gender. I mean intellectually. It's not a personal comment. In general, when you look at inequalities in health, men have bigger inequalities in health than women. And we documented that in my 10 years on review. The social gradient was steeper for men than for women. So that much was clear. And when we years ago looked at the East-West differences in life expectancy across Europe, the disadvantage of being in the former communist countries of Europe was bigger for men than for women. And it seemed to be part of a general phenomenon that when you've got conditions of social disadvantage, as characterized the former communist countries of Eastern Europe, when you've got conditions of social disadvantage, men seem to be more susceptible than women. That's what the evidence seems to show. In my 10 years on report, we pointed to the fact that women in the most deprived 10% of deciles on the index of multiple deprivation outside London actually had a decline in life expectancy. So although the inequalities were bigger in men, it was actually women in the bottom 10% who actually had a decline. For men in the bottom 10%, it didn't improve very much, but women in the bottom 10% actually got worse. So now you can understand what I mean by I'm slightly confused, because I had this nice clear picture that men are more susceptible to social disadvantage than women. Now when we turn to COVID-19, is the excess in men because of social disadvantage, or is it, as I've heard biologists speculate, women are more biologically robust, have better immune systems. We know women live longer than men, which I think is biological, not social. I think everything's social, but I don't think that is. I think women live longer than men for biological reasons. And whether that relates to women's relative protection from mortality from COVID-19, I don't know. But I think it's a very important question. And I need to put my spectacles back on. About the UK versus the US in health systems, the US is unique among high-income countries in not having universal health coverage. The Commonwealth Fund does a regular survey of 11 countries' health systems, and the US ranks bottom most of the time. The NHS ranks top in equity of access, but health systems across Europe, they do it differently in different countries, but they all more or less guarantee uniform, universal health coverage. So the US is unique. It's a distinct outlier. The Swiss are very proud of the fact that they've got an insurance-based system with private practitioners and so on. They seem to achieve universal health coverage their way. So we all do it differently in different European countries, but we all get there our different ways.
So my point, Professor Marmot, was not to sort of ask you to compare with the United States further, but was to ask you for your views in respect of which healthcare systems have better outcomes and less health inequalities than our systems, rather than just sort of lumping all of the other European countries together. What I'm effectively driving at is who is better than us. I accept from what you're saying that the United States is worse than us, but who is better than us?
Well, when I look across Europe, and there was a recent report from the European Office of WHO, they claim, and I'll allow them this claim, that only about 10% of the health inequalities of a country can be attributed to differences in the healthcare system. So most of the health inequalities we see in different European countries are due to social determinants of health, not to differences in functions of the healthcare system. So when we compare inequalities across countries, we're not actually learning very much about inequities in the healthcare system. We're learning much more about inequities in society more generally. And when we look at that, it's a very vexed question. It relates to some of the kinds of difficulties that were discussed earlier. Interestingly, the Mediterranean countries seem to have narrower health inequalities than we do. Not the Nordic countries. My prejudice would be that the Nordic countries would have narrower health inequalities. They do, but it's actually Italy, Spain, seem to have narrower health inequalities than we do, which is really interesting. You put sunshine, olive oil, goodness knows, the Mediterranean diet, what that's about. But that's what we seem to be observing. And I don't think it's because of outcomes of the healthcare system. I think it's much more general than that.
Okay, thank you. Could I direct my next question specifically to you, Liz, in respect of data? We have seen, as we see the daily press briefings, we have seen that the statistics that we're looking at and we're comparing with other countries, that and it's been highlighted today already, the differences in data gathering, the quality of data, and that clearly poses some difficulties for us as a country in comparing our the impact of the virus here with our other countries that are facing the same challenges. Can you tell me what the ONS is doing to improve its own data gathering in respect of people with protected characteristics here? And can you also highlight to me what work is being done to be able to establish and clarify to a better degree the level of excess deaths that we've had here in this country in comparison to other countries who are recording their deaths slightly differently? And I think one of the key issues that sort of has come to my mind, we appear to be recording all deaths with COVID, and I believe that some other countries may only be recording deaths because of COVID, and what work, if any, is being done by the ONS to extrapolate that data?
Yeah, thank you. Thanks very much for that question. So there are a number of parts there. What are we doing as ONS to improve coverage of for people with protected characteristics, I think was the first part. So we, as I've already mentioned, I think we publish each week a large range of death statistics now, both overall deaths and deaths involving COVID-19, and we have those available with age and sex breakdown. So that's already available. I previously mentioned that we've done some analysis to link our death registration data to the Census 2011 data, which is allowing us to look at more protected characteristics. So that's allowing us with the ethnicity release tomorrow, but then it will go on and be able to look at, for example, religion in due course as well, and it will build up our evidence base on deaths by different protected characteristics. So that's some of the work that's going on internally to ONS about improving our own. It's more challenging on the international picture and making those comparisons, as we've discussed before. So we are in contact with our colleagues in other national statistical institutes, and that is a way of us sharing both how we're approaching these issues and seeing what they're doing. And I think over time we'll see more countries producing the sort of disaggregated data that we're producing in the UK, and as we were discussing previously, those international comparisons will become more possible over time. One of the things we've been really keen to do in ONS is try and help explain to people how these different data sources interrelate with each other. So very early on, people were interested to know how the daily figures on deaths produced by DHSC each day compared to our weekly death registration figures. So it was really important for us to be really clear about the differences there. And so each week, along with our publication, which shows our own weekly death figures broken down by those splits that I've mentioned, we also put out a comparisons piece, which shows how the data compares across different data sources and what inferences you can and can't draw as a result. And I think being very clear about what is behind each data source and what comparisons that you can make is important. And in fact, it's that which is challenging in the international comparison space, because we don't always have that information in other countries about exactly the methodologies that's been used, which means that when you're trying to compare across countries, then you can't always see straight away what some of those methodological issues will be. Over time, I think we'll resolve a lot of those issues and the comparisons will become easier, but that will take some time.
Thank you. In terms of doing the disaggregation of the data in order to establish those people with protected characteristics and the impact on them, how much further work is there to do on that? And are you getting the full support of government in terms of everything you need to do that?
So the additional work linking to Census 2011, we have what we need to do that in the office. It's quite complex, and we are obviously wanting to make sure that linking different data sets always is analytically quite tricky, and we want to make sure that we get that right. But obviously the first publication from that work is coming tomorrow, so I think that's really good progress. We'll carry on for age and sex, continuing to produce that disaggregated every week, so that will continue to be available. There are some protected characteristics that were in the 2011 census where it's much harder to think about how one might approach that, and that includes, for example, sexual orientation. So that's more of a challenge.
Okay, thank you. No more questions, Chair.
Peter, I think Imran wanted to come in on those questions. If you could make it brief, please, Imran.
So, Peter, just very specifically on your question about whether this was predictable or not. So we know from other times that inequality on some important dimensions in the UK has been increasing since the 90s, say in terms of household earnings. And we know that, say, when we're hit by shocks such as the financial crisis or just economic downturns, that does have impacts differentially across the income distribution. For a health type shock, it's not that surprising that it's amplifying health inequalities that were there before. And it's very difficult in a short space of time to think about policies that are going to really mitigate that in the short term. So I think the crisis has amplified some inequalities, but not all inequalities. For individuals who hold have a private pension and a lot of their wealth is tied up to the valuation of the stock market, those households tend to be relatively well off to begin with, and they've seen a large decrease in their wealth, and that's reducing inequality in that sense. But we do have other dimensions of inequality that we never considered to be that important that have really been highlighted by the crisis going forward, whether it's in terms of the ability to work from home, having access to broadband, having access to green spaces, that might in the longer term have very important implications for how we think about the impact on mental health and other types of outcomes of the population. But I think the real sort of billion-dollar question is, do we think of this as sort of a once-in-a-century event, or do we think of this as that is predictable in something like this could happen again? We've known from other literatures that the frequency and complexity of viral outbreaks has been increasing over the last 30 years. The forces driving that are rises in global temperatures, increases in urbanization, and increasing contact between human and animal populations. Those trends are going to be very hard to reverse, and so we're seeing these outbreaks occur more and more frequently. The question is, to what extent do we want to almost pathogen-proof the economy? And if we do want to go down that route, how do we think about future crises? For example, imagine we had an outbreak which affected international travel. Then you'd imagine that's going to impact different sectors of the economy. Or if we had a crisis that targeted children or pregnant women or different parts of the population. So how do we, this is the real challenge going forward. How do we think about all of these dimensions and what might be a robust set of policies to have in place? And it's not just about the particular characteristics of COVID. Obviously, those will dominate in the short and medium term. But in the longer term, it was predictable in the sense that something like this was going to happen eventually. And so the question is, what do we think of as being the important ways that we can respond to these types of crises when the epidemiology of those crises may well vary over time?
Thank you for that, Imran. Can I bring in Kate Osborne, please?
Hi, hello there. My question is to Professor Marmot. We've heard that some groups, such as LGBT plus people, may be at greater risk from COVID-19 due to existing issues and or morbidities being higher than in the general population. Does this follow with any of the research that you have done? And do you think there needs to be more work on this area?
I have no data on LGBTQ plus subgroups of the population in relation to the kinds of analyses that I've done. So I can't really comment. I think the likelihood is that that we kind of understand a lot of the issues, and where they fall on that socioeconomic spectrum will affect what happens. But then there are other issues like discrimination, social isolation, which are likely to affect people's access to the things that are important for health. But this is coming from speculation, and I'm more comfortable talking about the evidence.
Okay. The committee has, thank you for that. The committee has heard that charities such as Shelter have reported a high volume of LGBT young people who are in need of help since lockdown, particularly around housing and the risk of them being homeless. I know you say that you haven't really got figures around this, but just wondered your opinion on why you think this is the case and what could be changed to protect this vulnerable group.
Well, firstly, we quoted in my 10 years on report, we quoted figures from Shelter that suggested that 1/3 of employed people are one paycheck away from being homeless. Now, to the extent that belonging to one of these protected groups, and particularly LGBTQ, puts you in that vulnerable situation because of discrimination or for whatever other reason, then you will have a condition of being in danger of being made homeless. But I can't, so I'm only speculating about how belonging to a particular subgroup might put you in a condition of vulnerability. But the responses in relation to the pandemic have made a huge difference. People actually being forgiven their rent or their mortgage repayment if 1/3 of the population were one paycheck away from being homeless without taking steps to forgive mortgage repayments or rent, we'd have an epidemic of homelessness on top of everything else, which is catastrophic for people's health. Talk about amplification of health inequalities. So, as I say, I can't comment on the specifics of your question, but the general issue of homelessness is one of immediate and urgent concern.
Thank you. I'd like to move on to regional inequalities, if I can, and again direct this to you, Professor Marmot. Dr. George Ray the British Medical Association's regional chairman for the North East has written an open letter to say that the area is suffering disproportionately, with figures showing that more than 7,000 people in the North East have tested positive for COVID-19. And the figures seem to show a disproportionate amount of serious cases and deaths. And it seems to have shone a light on the health inequalities in the North East. Can you tell me, is the economic impact of COVID-19 likely to be felt equally, in your opinion, across the UK regions and nations? And do we know which areas have been or will be hardest hit by COVID-19 in terms of income, employment, and low health outcomes?
So, two responses. Firstly, we've known for a long time, and I referred to this in my 10 years on report, that if you look at the social gradient in life expectancy, it's true everywhere in the country. The more deprived you are, your area, the shorter the life expectancy. But the slope of that gradient varies by region. It's steeper. The gradient is steeper in the northeast and the northwest than it is in London and the southeast. Another way of saying that is, if you're in the least deprived decile on index of multiple deprivation, in terms of life expectancy, it doesn't matter where in the country you live. You have relatively long life expectancy. The more deprived you are, the more it matters that you live in the north compared with London and the southeast. The greater the disadvantage of being in the northeast and the northwest. The gradient is steeper. And as I mentioned, when I was talking about gender, and in fact, in those northern areas, life expectancy for women in the most deprived 10% actually went down. So the second part is that when the Prince of Wales was infected, and the Prime Minister and the Chief Medical Officer and the Secretary of State for Health and Professor Neil Ferguson, and when high status, but Tom Hanks, when high status people were reporting COVID-19 infections, and you say, yeah, that's kind of what you'd expect. There's a lot of mixing, traveling around, shaking of hands, being out there, and you'd expect London to get it more than elsewhere. For all those reasons, we're all catching the tube and crowded, and buses, and it's very crowded, mixing, people coming from other countries. So just as you'd expect high status people to get it initially, you'd expect London to get it initially. And that's what seemed to happen. Then, as we've been saying, as the pandemic really bites and social distancing measures are implemented, and for all the reasons we've been saying, the lower down you are, the less able you are to exercise social distancing, the more we see this familiar pattern. The greater the deprivation, the higher the mortality from COVID-19. And the higher the admission to critical care units. So the fact that it looks like the infection rate, although those figures are very suspect because of the lack of widespread testing, it does look like the infection rate, which began in London, has now been overtaken by the Northwest and the Northeast, utterly predictably, for the reasons I've just been saying initially about the social gradient in mortality and life expectancy being steeper in the Northeast and the Northwest. So there's something about being towards the bottom of the deprivation spectrum and being in the Northeast or the Northwest that puts you at particular disadvantage in terms of health. And so it's predictable it would put you at particular disadvantage in respect of COVID-19.
Thank you. And following on from that, if regional inequalities are likely to be exacerbated by COVID-19, what response do you think is needed by the government to tackle these inequalities?
Well, forgive me for keep referring to my report of February, but that's what I thought was needed. When, as I said earlier, when we launched it, I said, we will give the Prime Minister what he needs in order to implement his levelling up agenda. And we went through what was needed, reducing child poverty, having Sure Start children's centres or the like for improving the quality of early child development, investments in education, employment and work. So we went through each of those domains, and that is what's needed to change the fortunes of people in the more deprived regions of the country. I don't think it's a mystery of what we need. I think we know what we need. The evidence that we compiled says what we need. So we've, in a sense, produced it and said, right, do it. Now I can see why there are other priorities right as we speak. But that said, we shouldn't neglect what's needed both to deal with the longer term underlying issues of health inequalities, which show these big regional differences, and dealing with how we prevent more urgent problems as we emerge from the pandemic.
Okay, thank you very much.
Imran, did you want to come in on that? Oh, I don't know.
Can you hear me?
Yes, we've got you now.
Okay, just to pick up on the geographic patterns of the crisis, this is something we started to look at in a bit more detail at IFS. And so I think what makes the crisis unique and is different from, say, the financial crisis is that it's affecting families and businesses through so many different channels. And so we could think about three different dimensions to the crisis. One is the health dimension, one is the economic dimension, and the other one could be the impact, say, on vulnerable families and vulnerable children. And so what we've been trying to document and understand is what are the geographic variations along all three dimensions, and how do they relate to each other? And so what we find is that in terms of vulnerable children or vulnerable families, that's very highly correlated to standard measures of deprivation across local authority areas. However, when we look at the economic impacts of the crisis, say as driven by workers, the share of workers in an area who are employed in the shutdown sector, that actually turns out to be negatively related to how we would normally measure deprivation. It's actually the least deprived areas that had the biggest economic shock, where the health shock is somewhat in between. A good example of that is London, where workers, a large number of workers are in shutdown sectors, but workers in London are more able to work from home, for example. So the normal patterns that we'd see in terms of economic deprivation don't play out on all margins of the crisis in the same way. And what we're finding is that these different elements of the way in which local areas, local economies are being hit aren't very correlated to each other. Those parts of the country that are being potentially impacted the most on the health dimension are being less impacted on the economic dimension. And similarly, those parts of the country that are being most hit in terms of vulnerable families and social care and child referrals are being less impacted, say, by the economic dimension. And so it actually becomes quite a complicated picture. There are some local authorities that are being hit along all three dimensions. Those with old populations who are in poor health, who are reliant on tourism and have pockets of deprivation in them. There are a number of local authorities which are really going to be hit along all three dimensions, and we're trying to classify different areas to the extent they're being hit on multiple dimensions. But this then raises the question sort of what should be the optimal policy response when we have such geographic variation. And there's been a lot of support that's being provided to local authorities, and local authorities are being hit in two ways. One is sort of their revenue, say through business rates, has fallen, and that's related to some aspects of the economic shock. And yet their demands for expenditure related to social care and vulnerable families has increased. But it may not be in the remit of local authorities to deal with all three dimensions of the crisis. And so there may be new policies, policy instruments that we need to think of. But certainly in our preliminary work, the geographic variation of the crisis is very complicated. It depends on which dimension of the crisis you're looking at, and they don't always overlap, with some authorities being hit along all three dimensions and others really being hit along one.
Thank you. Can I turn now to Angela?
First of all, can I direct my first question to Professor Marmot? You touched briefly earlier on the issue of socio-economic disparities. Now, the government has introduced a number of measures to protect public health. Are there particular groups that you think will be most affected by these measures, and could you outline specifically which groups and why?
Well, let me start at what I was going to just add, to start by picking up what Imran said, that we documented, if you look at the spend by local authorities, that the reduction in spend over the last decade was intimately related to degree of deprivation, which is regional. So the poorest 20% of local authorities had a 32% reduction in spend per person, and the least deprived 20% had a 16% reduction. Liverpool had the steepest reduction of any city over a certain size, something like a 48% reduction in spend. So there's huge regional differences related to deprivation on spending by local government. We're concerned about social care. So if you look at the social care element, adult social care element of those figures, the reduction, Imran will be pleased, I'm quoting IFS figures that we produced in our report. The reduction in social care spend was something like 16% in the most deprived 20% of local authorities and 3% in the least deprived, and it was a gradient. And then public health budgets have been slashed. That the public health spend went down dramatically. Public health was moved into local government, and given that local government was being cut the way I just described in a sharply regressive fashion, that limits the ability of public health to respond. They're in a local government that's been sorely restricted, and the public health dedicated budget was cut quite dramatically. So I'm not quite sure what specific public health arrangements you're speaking of, because we have in a fairly difficult position nationally on social care, on public health, and on general ability of local government to respond because of the powerless financial position in which they found themselves.
Okay, I appreciate that, and I'm conscious as well, you are correct, that in many cases it is the activists and local volunteers who are in many cases filling the gaps, as many healthy local volunteers are providing food and medicine deliveries for people unable to leave their homes. As many of these volunteers will potentially return to work, what suggestions or measures would you suggest to governments in order to ensure that those who are the most vulnerable and who will need to continue to shield get that support if there is a reduction in local authority funding available?
Well, I mean, I think the government has obviously got huge decisions to make. My own view, for what it's worth, is that I'm encouraged. I was asked this question on Newsnight the other night. I was encouraged by the Prime Minister saying, no, we don't want to talk about austerity. Good, because I think it would be a mistake for the reasons I've just been pointing out. We need to be looking at how we fund local services properly, because there's the need as Imran said, the need is increasing for local government. And as I had talked to people in local government before the pandemic was upon us, they were saying we can provide very little other than our statutory, those for which we have a statutory duty. And even some of those we're having difficulty with. So it's vital to look at what local government needs to be able to do, and is it funded appropriately? Again, as Imran said, its revenue locally will be hard hit by the economic downturn. And so it's going to be highly dependent on government funding. So it's going to have to look at that. And volunteers are very welcome, heartwarming. The third sector is vitally important, but that's also been cut. Funding to third sector organizations has been drastically hit. And so volunteers need organization, and the voluntary sector has a very important role to play, but that needs to be funded properly too.
Okay, thank you very much for that, Professor Marmot. Now, turning, of course, to Professor Rasul, you touched briefly earlier on the impact on minority groups, so Black, Asian, minority ethnic, and the impact of intergenerational households. Those who are designated as key workers during lockdown will experience particular impacts. But what research have you done on the characteristics of key workers and how they might be specifically affected?
So we've looked at a variety of different dimensions across key workers, and again, the underlying sort of repetitive messages that not all key workers are alike. That when we compare key workers as a whole to non-key workers, the differences aren't very stark to begin with. But then when we look key worker by sector, that's when we really start to see that not all key workers are the same, and there are very different compositions within them. So one big difference to begin with is just in terms of gender. So 25% of women who are in the labour force are in one of the key worker sectors. 60% of all key workers are women. But again, there's very big differences across key worker sectors. So women represent the majority of key workers in health and education, corresponding to about 70 to 80% of all key workers in those sectors. Whereas in other key worker sectors, such as public order and transport, they constitute about 20% of workers. So the gender dimension across these key worker sectors is very important. The age structures across key worker sectors are also very different. And there, I mean, the food sector really stands out as having quite a different age structure to other key worker sectors. So, for example, just over 16% of key workers in the food sector and about 40% of farmers are 65 or older. That's one of the key worker sectors that has the oldest population amongst it. And that's almost 3 times as high as for the workforce as a whole. In terms of country of birth, again, there are quite large differences across different key worker sectors. Most key worker sectors have a large share of workers who are foreign-born, between 15 and 30%. Again, the food sector is the sector which has the largest share of foreign-born workers, close to 30%. And within each key worker sector, amongst the foreign-born, the majority tend to come from outside the EU. And so there are clearly going to be implications of think about those issues going forward. Key workers also differ tremendously in terms of their underlying pay and the extent to which key workers are low paid. So on as a whole, key workers are more likely to be low paid. About 1/3 of them earn £10 or less per hour. And that compares to about 28% of workers in non-key worker sectors being at that part of the wage distribution. But in some sectors, the pay of key workers is even lower. So 71% of food sector workers and 58% of employees in social care earn below £10 per hour. That's below the long-term target for the national living wage. And conversely, at the other end of the distribution, non-key workers are more than twice as likely to earn £30 an hour or more. So there are big differences in terms of the pay for these workers, and that partly drives, who's able and who's willing to enter these sectors to begin with. So there are big differences by gender, age, wages, and country of birth across all of these key worker sectors.
Okay, no further questions from me, but I'm conscious that Liz wants to come in.
Thank you, Liz, if you come in now.
Thank you very much. I just wanted to flag that we have an additional statistical publication coming out on key workers on May the 15th, and that will, as well as looking at some issues around protected characteristics, it will also explore some new issues like how much public transport they use, which I think is another important element here. We've also used our opinions and lifestyle surveys, so that's our new survey looking at the social impact of COVID-19, to ask about the concerns that key workers have, and I think perhaps unsurprisingly they're more likely than other workers to be concerned about their work, and to raise specific concerns around health and safety and increasing their hours.
Thank you for that, Liz. Peter, was there something that you wanted to come back on that one of the witnesses had previously said?
Yes, thank you, Chair. I just wanted to ask Professor Rasul, as he was talking about regional inequalities, and you alluded to the need for specific policies to deal with those. Putting you on the spot, if I may, have you got sort of a top 5 key policies to tackle those regional issues?
Well, I think that the point that I wanted to emphasize was that different parts of the country are being impacted in different ways by the crisis. And so whether we think of the health, economic, or the vulnerable families dimension might require different policies, not all of which will be in the remit of local authorities, which are also observing lower revenues, say through business rates, and higher demands for expenditure, say through social care. So this might require some policies that, we haven't had the ability or haven't had the need to try to implement before, but it is going to be a complicated picture given these differences across different areas. So I don't have any one policy that I think will deal with all of these elements. And the additional complicating factor is, then presumably the demands and to come out of lockdown, the speed at which that occurs, might be different across different regions. Some will gain more economically in the short term, others will have older populations there who presumably would rather, have a slower exit from the lockdown, everything else equal. So that's going to raise some issues about inequality across areas and how they're being currently impacted and how they might be impacted in the future. That might require a whole new raft of policies that we haven't currently really seen, because a lot of policies have been thinking about one dimension in isolation, but the same parts of the country being impacted in very different ways.
Do you have any policy ideas for us?
So I think the key role of government here is to make sure that when policies are communicated, in a sense that they're both communicated credibly and with certainty. So a bit like as we require of the Bank of England to give us forward guidance, I think to minimise the uncertainty that households have of how the lockdown will be exited, I think will be a key element of how government responds. If households are uncertain about what's going to happen in the future, then that can lead to people taking precautionary behaviours that might try to undo some of the policy impacts that we're trying to have. We saw that coming into the crisis when some households started to stockpile. You don't want to start those kinds of precautionary behaviours as we start to try to predict how we're going to move out of the lockdown. And there it's important to see and obtain data on what are households' expectations about what's going to happen in the future. So there have been some real-time surveys that have been conducted in the UK asking households, for how long do they expect to be furloughed? For how long do they expect their income to have been reduced? And so there's a team working out of Oxford, for example, that have surveyed UK households, where they find that in the UK, about workers expect to earn about a third less for the next 4 months compared to normal times. The average probability that they perceive of losing their job within the next months is about 30% in the UK. That's fairly similar to the US numbers. In Germany, it's about a quarter of people expect to lose their job in the next few months. So there are differences across countries in the expectation of the economic severity, but I think those kinds of expectations that households have very much need to be factored into the way that information is presented to them. we know that households might respond differentially to the same information, but it's key to make sure that we minimize that uncertainty.
So clarity and certainty would be your advice then?
Yeah, it's like forward guidance, but coming out of the crisis. And
thank you.
Can I turn to Sarah Brickliffe now, please?
Thank you, Chair. Going back to the economic impact, and this is to Professor Rasul. How might the overall economic impact of the virus affect certain groups? And do you think there will be some groups that are particularly vulnerable to this?
So we've mentioned before how groups differ in terms of their exposure to shutdown sectors, for example. And there's an interaction between minority groups and gender, for example. So when we look at shutdown sectors, you know, I mean, just to pick on a few, sort of Bangladeshi and Pakistani men are much more likely to be in a shutdown sector than white British men. Black African and Black Caribbean men are also slightly more likely to be in a shutdown sector. For women across different groups, the patterns are less stark. So there are different groups where men are going to be especially hit by being employed in a shutdown sector. Some of that is driven by differences in self-employment, as I mentioned. And then that feeds through into something that Michael brought up earlier, which is, you know, the extent to which households report being able to survive, you know, without any earnings or reduced earnings coming in. And so, you know, we see that about, you know, a third of white British households report being able to draw on savings at this time of crisis for up to 6 months. And that number falls to below 10% amongst Bangladeshi households, Black Caribbean households, and Black African households. So again, the resilience to the crisis is partly a function of the savings they've been able to acquire beforehand. That does vary across different groups as well. So I'd imagine that there will be implications both in the short term and how quickly households are able to recover from the shock.
So just on that, the data currently available to you, is that helpful in analysing this? And if not, what needs to improve with that data?
So I think we're in a very fortunate position in terms of the quality and speediness with which we have data. And, you know, just to reiterate what we said before, ONS has been an absolute, you know, gold standard for providing that and has allowed a lot of research to take place. However, there are a couple of points I also wanted to stress. That the remit of the committee is to discuss many different protected groups. There's only a subset of those for which we have sufficiently large samples to be able to discuss with any kind of scientific confidence. And those are really gender and different minority groups. But for other types of protected group, it's much harder to say anything because we simply lack the sample sizes to say anything beyond sort of anecdotally or in very select samples to begin with. So that's, in order to get those large sample sizes, that's where it's critical that we have a good infrastructure of administrative data in the UK. And at the Institute for Fiscal Studies, we work with a number of different government departments and their administrative data sets. And so I think we have those data sets exist, they're available for research, they allow these types of quantifications to take place. Where I would push would be for us to think about long-term investments and also linking across different data sets to allow us to do cross-tabulation, say, of people's labour market status with their children's schooling outcomes, for example. It's somewhat hard to always get enough sample in some of those cross-tabulations. And that might be critical at a time of crisis where, as I mentioned before, households are being hit on so many different dimensions. Any given administrative data set will only give you a very detailed picture on one dimension. That's what they're designed to be collected for, whether it's from the Ministry of Education or DWP or Ministry of Justice, whatever. But when we can actually link those, then we get a fuller picture of all the different ways that households are actually being exposed and all of the cross variation by age, by group, by gender, and other dimensions that might be incredibly important for how the crisis actually plays out in the longer term. So it's to continually invest in those data linkages. But I am very encouraged that some of the large household studies that we have in the UK have been funded by the research councils to have COVID-specific modules now going out to field, which will give us a very rich picture of 40,000, 50,000 households for which we have information from other time periods. to really get a grasp in real time of how households are responding to the crisis. So we've had a lot of investment in good data in the UK. Long may that continue. I think that really allows us to understand, be a world leader in those aspects.
Perfect. And what do you think is working well in relation to the economic response to COVID-19?
So I think the ability to target resources to furloughed workers, to target resources to self-employed workers has had a tremendous impact on those families. I mean, when you look, across countries, the extent to which they've been able to use their pre-existing infrastructures to get resources to those households that need it, I think is vital. Where the real challenges are now going to lie is how do we reverse those policies to an extent. When and how do we do that? And coming back to what I was mentioning to Peter, sort of what kind of guidance, what kind of certainty is provided to households about how those policies will be rolled back, because they're going to need to be to some extent. But this might lead us to think about more permanent changes in how we think about those kinds of a redesign of the benefit system, which has really changed a lot over the last few decades to really target in-work benefits and rather than out-of-work benefits. And potentially that might be an important issue going forward in terms of the most vulnerable households and communities.
And is there any that you believe need to improve right now?
You could always argue that things could be done better in hindsight, or but it's very hard that we face incredibly difficult times, incredibly difficult trade-offs. But underlying anything that we try to do, it's only based on the quality of data that we have, and that's really the bedrock and foundation of being able to actually come up with good ideas and actually understand where the problems are emerging. So I think my remit would be let's try to make sure we always have that data available to researchers to provide this as one of many inputs into the political process.
And my next question is both to yourself and Professor Marmot. Do you think that the safety net of benefits and assistance available at the moment will help to stop existing economic inequalities from worsening? And if so, why?
The benefits and safety net are of absolutely vital importance. One of the issues has been that they were not generous enough before the crisis, before the pandemic. They were not generous enough, and it was, to put it neutrally, a bit clunky in the way it was actually implemented. The well-documented problems of people accessing universal credit are well known, causing great difficulty, loans, food shortages, and the like. And they were not very generous. I mean, if you look at the minimum income necessary for healthy living, then the benefits available to families in need did not bring their incomes up to the minimum necessary for a healthy life. So this was not a way to live. Now, if the purpose of doing that was to encourage people to get into work, fine, that I can see the argument there. But if there isn't work, then having a benefit level set at a level that makes it incompatible with the minimum necessary for a healthy life the answer is no, that's not sufficient.
Thank you. And what do you think could be changed in order to protect the most vulnerable groups?
Well, in a way, Peter Gibson's earlier question about policies, which is a very important question and made me nervous just thinking about it. And part of how I'd respond to him is that at the heart of all policies should be concerned for the likely impact on health inequalities. And we know what things are likely to have an adverse impact on health inequalities because we've been studying it. That's what the Marmot review in 2010 summarized, and that's what my 10-year on review summarized. So we know what the key determinants are of health inequalities, and we should have regard in all of our policies to the likely impact on health inequalities. So if people don't have enough money to enable them to live a healthy life, that should have a big effect on the way we design policies in these very straitened circumstances in which we find ourselves.
Thank you, Chair.
Thank you. Can I turn now to Kim Johnson, please?
Thank you, Chair. My first question is directed to Professor Rasul. Professor, we've heard this afternoon about the disproportionate impact on some of the protected characteristics. So I'd like to ask you, what contribution would you say that 10 years of austerity has had on these groups and the increase in levels of poverty and social deprivation? And were these foreseeable? Thank you.
Well, I think as we discussed before, that there has been a long-run rise in inequality pre-crisis, and it's not surprising that some of those dimensions then get amplified during the crisis. But as Michael was saying, that perhaps it's welcome to think that in the future we're not going to go back to austerity, but we're going to have to find some other way to fund the short-term policies going forward. And so that's why, I mean, linking to the earlier question, the policy dimensions go well beyond sort of the benefit system and redesign of the benefit system, much as that may be needed, but also to think about how are we going to encourage firms to actually re-employ people at the end of the crisis and to maintain current matches. So we might also think of this as a potential opportunity to help firms to invest in technologies that allow more people to work from home, or to invest in other types of technology that allow the impacts of social distancing to be smoothed out across more workers, more sectors. Other elements that can be thought about are in terms of making sure that we provide assistance to workers who might need to work in a different sector to where they've previously been, and allow those types of rematches to take place. We have a large set of people who would like to work, currently unable to work. Is there a way to usefully employ them and to help those kinds of transition? And I think the other group that we haven't really touched upon very much are young people who are currently in the crisis of making a key transition, either between school and university or between university and the workplace. We know from a battery of evidence that graduating in a recession tends to be very bad for people's careers. It leads to lower likelihood that you're going to find a job upon graduation and lower earnings once you do find a job. And those impacts, those what are known as sort of scarring hysteresis effects, tend to last for up to a decade. And there's numerous studies that have shown how that group might be particularly vulnerable relative to people who graduated 2 years ago and people who will graduate in 2 or 3 years' time. So again, thinking about policies that might be specifically targeted to those individuals who are just transitioning into the labour force, either by allowing them or finding ways that they can switch jobs more quickly. That's been a key mechanism by which people can offset the effects of recessions, or encouraging voluntary work, or encouraging them to perhaps acquire more human capital and stay on in education, might be ways that we need to think about to sort of smooth the shock for those particular groups as well. So the range of policies is beyond benefits. It's also thinking about how can we work with firms as well as other groups that might be at risk. And those groups will be at risk potentially for the longer term. Some of these effects won't have a chance to be offset for nearly a decade.
Thanks, Professor Rasul. My other question, again, linked back to young people and other groups. Would you say that working in precarious and zero-hour contracts also has an impact on some of the groups, and the fact that young people get paid less money to do the same work as older peers also contributes to some of these disparities?
So we have seen there's a stark pattern that younger people are more likely to be employed in shutdown sectors. Shut down sectors are more likely to be low-wage sectors. Even amongst sectors that remain open, it's low-wage workers in those open sectors that have the least ability to work from home. So on a whole range of dimensions, young people could potentially be more impacted economically. And that translates into just the precarious situation that many households find themselves in at the bottom of the income distribution, where they have, very limited resources by which to deal with such shocks. And so I think, yes, young people would there are important age gradients here that would affect young people on the economic dimension over and above other dimensions.
And could I also ask, though, in terms of older women in the workforce, would they be impacted because of the changes in terms of state pension and having to work longer in these precarious and in frontline positions?
That's really not my expertise, so I'd prefer not to comment on that.
Okay, thanks, Dr. Rasul. That's all my questions for you. My next question is to Liz, and it's regarding the collection of data. You mentioned before about a report being issued tomorrow. Public sector organisations have a duty in terms of collecting information from their workforce. I just wanted to know, how is information collected from the private sector and the manufacturing sector in terms of these particular groups that we're talking about today?
So the report that we're publishing tomorrow doesn't take data from the private sector or other groups in that way. That's information provided by individuals in the census and then linked to death registration information. So in that way, we get that information. A lot of what we've discussed today about labour market impacts, we would use as our main source of information to get labour market information by different protected characteristics, our labour force survey. And one of the things that we've done there, so that we can understand better some of the impacts that we've talked about today, is added questions to that survey on things like whether people are as part of the furloughed scheme, so that when that information comes out later this month, we'll be able to see in more detail than on the evidence we have so far, how different groups are being affected in the labour market across different industries. One thing that we've already been able to do, because we wanted to immediately see the impact that different businesses were experiencing because of COVID-19, was to stand up a new survey, which we've called BICS, the Business Impact of COVID-19, which is a fortnightly survey that we send out to businesses, and we can find out information from that, such as what proportion of staff have been furloughed. And what we've been able to do already is look at how that compares to the makeup of individuals in those areas. So there's a number of different ways, I think, that we can get answers to the sort of questions you're posing there. Okay, thanks, Liz. And last question to you. What gaps are there in the data, and what data do you think that the government should be collecting? So I think we've already discussed earlier that it's easier to be able to produce analysis where the size of the protected characteristic group is larger, especially when we're using survey evidence. And so when you have survey, when you have a survey, if it's a relatively small size, then you are constrained by how far you can look at different groups as a result. And in essence, the larger the sample you draw, the more likely you are to be able to look at the different groups. So as we look at the different protected characteristics that we've looked at today, it's nearly always relatively easy to look at age and sex differences, also to look at ethnicity and disability differences, but then it becomes harder to look at some of the other differences. Different things that need to be done there. One is we have to make sure that we're asking for the information, and ONS plays a really important role in that respect by making sure that we're asking for the information in the same way. So we have harmonization teams in the office who craft a way of asking the question, so that when you're asking a question about disability or ethnicity in one survey, you're asking it in the same way in different surveys, and the same in administrative data systems. And that then allows you to make much more robust comparisons between different sources of information.
Thanks very much, Liz. Chair, do we have time for the last question to Professor Rasul and Professor Marmot?
Yeah, that'll be fine. Thanks, Kim.
Okay, so my final question then to both professors is, if you could ask three things of the government for the short term and further into the future, what would they be? Thank you both.
Well, if I may, I just wanted to respond to your pension question. Before that, if you look at the social gradient, not just in life expectancy, but in disability-free life expectancy, healthy life, then if the pension age became 68 rather than 65, which is government policy, 2/3 of the population do not have disability-free life expectancy as long as 68, looking at the social gradient by deprivation. And women spend more of their years, I said earlier, as you know well, women have longer life expectancy, but they spend more of their years with ill health than do men. So that the healthy life expectancy or disability-free life expectancy is more of an issue for women. So advancing, however you say it, making the pension age later will have a big impact on women because, as I say, given the social gradient, 2/3 don't have disability-free life expectancy. The more deprived 2/3 don't have disability-free life expectancy as long as 68. In relation to the ask of government, the number one that I've already said was I would like the Prime Minister to chair a cross-government strategy involving the whole of government to advance a health inequality strategy. Now, that was the number one recommendation of my report. As you know, the government has a stated policy of advancing healthy life expectancy by 5 years by 2035. They cannot possibly achieve that without addressing health inequalities. So to meet that stated government policy, now that was already before COVID-19, the number one should be that the Prime Minister should chair a cross-government activity to elaborate a strategy for dealing with health inequalities, which will relate to the aspiration to advance healthy life expectancy by 5 years by 2035. The second, as I said, and it relates to the first, is that all government policy should, in a sense, go through a health equity screen. All government policy should be looked at by its likely impact on health inequalities. So that's environment, economic, employment, education, every sector. And the third is, please read my report.
Thank you.
I just have one ask from a research point of view, and that's that, all evidence-based policy is only as good as the data it's based on. So just to reiterate what I said before, to continue to invest in both administrative data sets, some of the great survey evidence that we have in the UK, but also to think about how can we best link those different data sets together and give researchers access to that. It's only by looking at the same individual over time or linking parents and their children do we actually get the whole picture of how the crisis is affecting households. And that's what makes this crisis so different from anything that we've seen before. It's affecting households in so many different ways. And so it will be wonderful if we're ready for this for the next time, which will happen. Something like this probably will happen again, where we can link across these different health dimensions, the economic dimensions, and the family dimensions. I think that type of investment, in terms of the ability for us then to think, what are the issues, and to have the discussions that we're having today, that investment will generate huge rates of return in just the possibility to design better policies, because we just have a more holistic picture of all the different dimensions through which households are being impacted. So that would be my main sort of research-focused ask of government.
Well, thank you so much for your answers to my questions today. They're all my questions. Thank you.
Thank you. Can I conclude with a final question, which I'm actually going to direct to Imran, but I'm very happy for either Michael or Liz to chip in if they would like to. Right at the beginning, you spoke about the Zika outbreak in Brazil, and the response of the Brazilian government didn't include a gendered response to that crisis, notwithstanding the fact that we knew that it was a condition that affected pregnant women specifically. And that led to many women still traditionally having to go out and get food and cooking equipment. So knowing what we do about COVID, that it affects men more than women, should we be thinking about having a gendered response to COVID?
Okay, so one of the biggest puzzles, I think, in health economics is how people respond to information about their health and the health of individuals around them. In many other dimensions of life, when we're given information, it's fairly predictable about how people are going to use that information. But when it comes to information about your own health, there's all kinds of behavioral biases that tend to enter. So what we document in the Zika context is that not everybody responds to the health information that's provided. That may be for a variety of reasons. For some women, it's incredibly costly to delay pregnancy, especially those at the lower SES end of the spectrum. They're much as likely to become pregnant after the Zika outbreak as before. It's higher SES women that choose to then delay pregnancy, perhaps because it's less costly for them to change the timing of births. Conditional on becoming pregnant, we see similar changes in behavior during pregnancy of high SES and low SES women. So it's not that low SES women don't have information or don't respond to it, but how they can respond to it might vary. And then we also find that there's a group of individuals who became pregnant just before the health alert was made public, and they don't change any of their behavior during pregnancy at all. They're not more likely to ask for an ultrasound, an abortion, to go for more health checks. So it's almost as if some people tend to ignore the risks, the health risks that they're subject to, when in a sense they're already subject to them. And that just fits in with a sort of a larger body of evidence that when it comes to providing information to people, that may need to be targeted, that may need to be tailored. You might need to utilize other evidence in terms of how exactly you try to persuade people and convince them of certain messages. There isn't going to be a uniform way to do that across different types of households. And that's something that comes up repeatedly when we try to study how do people respond to information about health, whether it's that you shouldn't smoke, that you should wash your hands. These are things that everybody knows, but whether they act on that information actually turns out to be quite puzzling, the extent to which people don't. And so those are common findings that we have, and no doubt they're also going to apply to the extent that people are adhering to social distancing information that's provided to them, or other practices that have been suggested.
Thank you. Professor.
I think it's an excellent question. And I would respond in two kinds of ways. One is that there are some issues that are clearly gender specific. So the apparent increase in domestic violence consequent upon lockdown, if people are being cooped up in confined spaces and more women are calling for help. So that's a very gender specific type issue. And then there are general issues but might have gender-specific effects. So I pointed to the decline in life expectancy in women in the most deprived 10% outside London. And in my report, I didn't offer an explanation for it. I was just troubled, but I didn't offer an explanation. It was put to me after we published it. I looked at the House of Commons Library report from, I think, 2017 that claimed that something like 80% of the brunt of the policies of austerity had fallen on women. And I did point in my report to single parent households, but that's usually women, and cuts in child benefit and the like. So there are policies that will have bigger effects on one gender than another, not because they're designed that way, but that's the way it turns out. So in other words, there are two types of issues, some that are gender specific and some that might have differential effects on gender. And I would say with gender, we should do the same as I was calling for when I said all government policies should be looked at for their likely effect on health equity. And I would include gender in that.
Thank you very much. Liz, did you wish to conclude with any further comment, or are you happy?
So I'm happy, thank you. The only thing I would add to that is it just shows the importance of having the data disaggregated by those different characteristics, which ONS is what we're committed to doing.
Brilliant. Thank you very much. Thank you for everybody who has taken part, but particularly our three witnesses. I know these are weird circumstances in which to have to come and give evidence to a select committee, but that concludes our meeting. Order, order.
Can't you see it too? There's an elephant in the room.